Good afternoon again, everyone. Thank you again for joining us. Welcome to the 20th anniversary of the Lewis Stokes Health Sciences Library and the Vernon E. Jordan Law Library at Howard University. Over the next 2 days, we will be conducting this symposium named Challenges and Legal Implications of Misinformation in Health Disparities and Health Policies that Affect Minority Groups in the United States. I'm Dr. Sheila Brooks, CEO of a marketing agency in Washington, D.C. I'm delighted to be your moderator again today, and I'm a proud Howard alum. And now, without further ado, I'm going to introduce all of our panelists, and immediately followed by each of their presentations, we will then have a Q&A session. So please put your questions in the chat as they go through their presentations over this next hour. Let me introduce now Irene Chen. She is a computer science Ph.D. student at MIT, advised by David Sontag. Her research develops machine learning and data science methods to advance healthcare through the lens of inclusion and equity. She's been named a rising star in her field, not only by Harvard University, but the University of California, Berkeley, and the University of Maryland. Followed by her, we will then hear from Professor Carla Nunziato. Professor Nunziato is a professor of law and the William Wallace Kirkpatrick Research Professor at the George Washington University Law School. Also there, she is the co-director of the Ethical Technology Initiative, and she is author of The Virtual Freedom, Net Neutrality and Free Speech in the Internet Age. Without further ado, we will also have joining us Dr. Monica L. Ponder. She is Assistant Professor of Health Communication in the Kathy Hughes School of Communications at Howard University. She is the author of the Henrietta Hypothesis. Dr. Monica Ponder scholarship offers not only crisis communications, but recommendations for organizations seeking to engage historically marginalized and underrepresented groups during public health emergencies. She also leverages her career in health communication at the Centers for Disease Control. We will hear from each of these panelists. We'll begin with Ms. Chen, followed by Professor Nunziato, and followed by Dr. Monica Ponder. Immediately after all of their presentations, we'll regroup and we'll have Q&A. Thank you again for joining us. Ms. Chen, you can begin.
Thank you so much for the wonderful introduction. Give me 1 second as I set up. Can I get confirmation that people can see the, okay, great. Thank you so much. And apologies for the technical difficulties. You'd think after a year of Zoom, it would be a little bit smoother, but here we are. It is an incredible honor to be speaking today. I was born and raised in Atlanta, but we actually drove to DC a lot for family road trips. And we visited Howard University when I was about 10, and it's a beautiful campus. I hope everything is going really well there. Today, I'd like to talk a little bit about my research, specifically the part that focuses on treating health disparities with artificial intelligence. This is joint work with the whole team of collaborators without whom I would not be able to present this research and share some of our insights here. As many of you may know, there are a lot of known medical health disparities in the current system. So anything from illnesses like heart failure to mysterious reasons why different groups are experiencing disparities in outcomes and treatment, all the way to how people access care in the first place, is yielding some really concerning and alarming disparities that we can currently observe in the system itself. When we think about the data that is collected then in this kind of system, we are starting to observe that disparities can filter into the data itself. One example is in the genetic studies that are done, GWAS studies. 96% of all participants in these studies are of European descent, which you can imagine would start to bias and have impact on any kind of resulting algorithms that are made out of these data sets. And even clinical drug trials, sort of the gold standard of how we develop drugs and validate them, have found that they do not actually match the populations who are most at risk for these diseases in question. So this was a study looking at different types of cancer and determining which drugs were developed for which cancers and who was actually in the clinical drug trial in the first place. When we think about artificial intelligence, and how it fits in with this landscape of health disparities, a lot of people have raised concerns then that the data sets that we collect could be potentially biased, and any kind of models that we built. So this is where I come in, thinking about computer science and building machine learning models, could be potentially biased, opaque, hard to certify, potentially make the problem even worse. But, I'm here though to sort of pitch a different version. I think if we think of the glass as maybe half full as opposed to half empty, there are some opportunities that I'd love to highlight today. For example, we can start to incorporate massive data sets. We can actually start to analyze, in fact, populations that have been underserved by the current health system. And because of the wonders of machine learning and technology, and mobile app in everyone's hand, some of these algorithms are able to scale quickly and widely. And this could yield tremendous insight moving forward. Today, I'd like to walk through 3 ways that we can use artificial intelligence to treat disparities. First, we can characterize this disparity, figure out what's going on, quantify it, put a name on it, put an actual magnitude in it. Then we can actually fix any algorithmic bias. So we're taking these data sets, we're building an algorithm off of it. How can we figure out how to fix any kind of unintentional bias that may be encoded in the algorithm itself? And then lastly, I'd like to talk about how we can zoom back out, think about these systemic biases that I showed early on and how we might be able to address them using machine learning. So first, we're going to go into characterizing disparity. Some of you may have seen this study, but essentially there's a predictive healthcare algorithm used by insurance companies to allocate resources into the care management program. And what these researchers, some of my colleagues, have shown is that actually there's racial bias in this predictive healthcare algorithm. And what I mean by that is that the score, so this algorithm gives every person a score, and based on that score, it enrolls this patient into a program where they get additional resources, nurses call them more often, maybe they get vouchers to take public transportation. There's sort of a lot of support that comes if you get a high enough score. So if you're severe enough, you want a score that reflects your actual health need. What they found instead, though, is that a person would receive a score based on many factors. And in fact, when you slice it by the race, the self-reported race of the patient, a white patient would only need to have about 4 chronic conditions, and a Black patient would need to have about 5 chronic conditions to have a risk score in the 99th percentile. This is quite concerning because this algorithm was actually used for millions of people and to allocate resources and to govern their care at a health insurance level. So this is incredibly concerning. And in fact, just as a quick coda, senators got involved and to think a little bit about how policy can start to shape this. There was a hearing, and there's sort of a lot of questions now about how different healthcare insurers should think about how they allocate resources, assign risk scores, and how we can make sure that any algorithms that affect millions of people are being validated in a bunch of different ways. Similarly, we want to be able to use the data to characterize what's going on, what kind of needs are out there. One of the ways to do that is actually leveraging maybe more creative uses of data. So this is one of my colleagues, Henrietta, who is at UC Berkeley, and she looks at whether or not you could use search query traffic in order to determine what areas have the greatest need for different diseases. And through this, because collecting data manually can be very difficult, very time consuming, using something like a search query data set, she was able to work with Microsoft and Bing data to map out what the areas of greatest need would be for a bunch of different diseases. And then in my own work, I've looked at psychiatric notes to look at figuring out what kinds of patients might be well served by the existing algorithms and what kinds of patients are not. So we can do what's called a topic analysis. So this is an unstructured look, taking just all the notes and seeing what kind of patterns appear. And one salient topic had sort of the highest degree of a concern about bias potentially, and that ended up being about substance abuse. So thinking about, you can see all the words, use, substance, abuse, cocaine, mood disorder, sort of all characterizing these types of patients that we should be particularly concerned about, and then figuring out how to then, as we'll discuss in the later of the presentation, figure out how to address any kind of disparities that arise. So there are, I would say, a lot of unmentioned biases in this case. And it's important then that we start to look at what's going on, what kind of disparities might arise that we might not have expected, but now that we have access to all these data sets, here I mentioned risk scores from a care management program, Bing search queries, psychiatric notes, we can start to get patterns and get some more information about what's going on in the first place. Something I do want to sort of seed for the rest of the presentation then is that we are actually assuming that the data sets exist sort of from the sky, perfect, well cleaned and everything. And in fact, who's inside and outside of the data set is also a matter of concern. So I want to sort of bring that up as we progress. The next thing I'd want to say is now that we sort of can show, for example, in the first case, the risk scores for this health insurance algorithm, there were disparities, there's algorithmic bias. How could we start to fix them? What are the sort of tangible next steps that as dedicated, concerned policymakers might be, or even model practitioners or anyone who touches an algorithm in any way might be able to start to enact change? One of these is to think about the trade-off between accuracy and fairness. So actually, when I started my PhD about 5 years ago, this was all the rage. There's sort of an understanding that maybe you want a really good model or you want a really fair model, but you cannot have both. There's always sort of a trade-off about figuring out what's going on. And in fact, there's a whole body of work that looks at quantifying this disparate impact of an algorithm. So group A is getting much less error than group B. And so the difference, we call that a disparate impact, and figuring out how to maybe make the difference a little smaller at the cost of maybe increasing error. In something like a healthcare setting, this is a non-starter. I think most clinicians, policymakers do not even want to discuss this. So the question becomes, how can we then bring more tools in so that we don't have to sacrifice accuracy and fairness right back to back? The other option, and this is something that we've now worked on, is thinking about how we can consider both the algorithm and the data set we collect itself. Traditionally, a machine learning model will take in some data, be trained on that data, and then for any new data, it can predict what's going on. So maybe looks at all the past patients who's come in, let's say with COVID, who's going to respond well to treatment or not respond well to treatment. And in the future, you could recommend treatment for new patients who come in. Problem is that often we only look at the machine learning model part and we don't think about what data are we feeding in the first place. Fortunately, in statistics, there's this concept of bias, variance, and noise. And using that, we can start to break down how it impacts the model, how the data has been impacting the model and the errors, and recommend ways to fix this moving forward. So for example, if this is sort of a very light mathy slide, but essentially, depending on which term, there's sort of tests you can do to figure out which term is contributing to the unfairness of a model. You can then use that, use your knowledge of which term is contributing to then enact different changes. So for example, sometimes the data set is very small. If we knew that the sample size, so how much data we have of each different groups, if we knew that that was the impacting the unfairness the most, we would improve the sample size. We'd take $1 million and we would go to town and just collect a ton of data. However, sometimes there might be actually noise in the data set. And this means that even if you collected 1 million data points, 1 billion data points, there's actually noise in how you collect it. Think of it like taking a picture, but it's super blurry. In that case, as much data as you need, it wouldn't help. So then being able to narrow it down to noise would be helpful, because then you could say we should get a better camera, maybe make a video so we can get sort of more angles going on in order to collect how many features, how many measurements we have, what types of measurements we have. Similarly, we can think about model class, about a linear model or nonlinear model, bring in a deep learning network. Those are all factors that we should take into account as we start to build our models. So a little bit more math. The sort of takeaway then is methodologically, computationally, how could we realistically estimate these values? And then also different noise rates for different groups might be different, in which case we need to be very thoughtful about how we collect measurements and how we recommend policy changes. To wrap up, we looked at intensive care unit predictions as well, and we found racial differences. So in the 0-1 loss and the error, we could also fit these inverse power laws to estimate the benefit of getting more data. So when we recommend you should just get more data, we actually know, if you get more data, we think that it'll make the model this much better. And we think that the bias will go to here, but actually might not be solved completely, in which case you may need to look at where the noise is greatest. And for this, we looked at different subpopulations, for example, cancer patients and cardiac patients. All right, I was told to present for 15 minutes, but then I had technical issues. So I'm gonna breeze through the last part, and I'd love to answer any questions that people have in the question and answer section. So the last section I wanna talk about is a little bit broader than just one model or one data set. And this is the acknowledgement that we exist in a system that is inherently biased systemically, just overall. And there's many different kinds of disparities that might pop up. For example, there might be disparities in access to care. There might be disparities in treatment. So if you have the same condition, you might get treated differently. But also if you have the same treatment, it might impact people physiologically in different ways. So understanding how treatment impacts people is very important. And then there also might be disparities in outcome, thinking about life expectancy, maternal mortality, all of these different measurements that we have that we know are not equal across different racial groups, different gender groups, any kind of subpopulation that you might be concerned about. I want to talk a little bit about discovery, scientific discovery. And this is the notion that we don't really understand diseases that well. There are actually many diseases that we call just asthma, but actually are several different kinds of manifestations. They progress differently, they can get treated differently, they pop up in different types of people, and we don't understand them that well at all. As autism is another example, heart failure, there are many different diseases that get called the same name, but actually are maybe 4 smaller diseases lumped in together. And when we look at the clinical data sets to build these algorithms in the first place, they can be quite complicated. Here we have the lightning bolt is the beginning of when they enter the system, like when they go to the hospital for the first time. And then some people might be have different measurements at different times and having different adverse events, for example, patient mortality. We might be interested in doing some sort of prediction, in which case we need to figure out how to align patients up so that we can predict in 6 months, what's going on. One way to do this might be just sort of aligning by a patient mortality, say like 1 month before death, 2 months before death, what does it look like? Problem is then we lose all the patients that don't have death measured. If we align by when they enter the system in the first place, that could be tricky because maybe people have different access to care. And as a result, the data set might be skewed by aligning it improperly. This is called left censorship, meaning that we don't know when all of the data starts at the same time. And this can occur because all kinds of barriers to access to care. For example, there might be medical mistrust, historical medical mistrust. There might be geographic proximity to hospitals. Rural hospitals are closing at a dramatic rate, or it's quite simply just access to health insurance, which I'm sure everyone here is aware is a barrier to health access. We built a deep generative model that maps patients to a latent space. So all these complicated features, and they go to a very simple latent space that we learn. Patients who are close together would be more similar. So these two patients are pretty different. But these two patients, actually B and B plus, are the same patient, but one patient just came in a little bit earlier, has some more measurements before, but they are essentially the same patient, and they should be close together in the latent space. Once we learn this latent space, then we can learn these subtypes and be able to validate them on clinical data sets, which we did. I want to wrap up though, this is a whirlwind of research, but I want to sort of challenge the community, anyone who's listening right now. It's three sort of takeaway facts. One is to think about how to expand beyond the mathematical definition. This is specifically an egregious thing in my field where everyone is very into math and wants to solve everything with math. Maybe there's sort of other things outside of the math that we should think about. The second is to seek and promote different perspectives. I'm a computer scientist. I work with ethicists. I work with clinical collaborators. I work with anthropologists to figure out how my research is contextualized. And then lastly, there's a lot of low-hanging fruit. A lot of startups are trying to get rich quick, do short-term prediction. And in fact, everything fits in a giant system. And so thinking about the way to improve the whole healthcare system will be beneficial to us long-term. Thank you so much for your attention, and I look forward to hearing your questions.
Would you all like me to go ahead with my presentation? Can do that and get ready to do that. Can everyone see my screen and hear me?
Yes, we can. Thanks, Professor Nunziato. Please go ahead.
Great, thank you. Thank you so much.
Thank you.
And thank you to everyone at Howard University. Thank you to Jeremy for inviting me, and to Dr. Brooks for moderating and leading us today. Also, thank you to my research assistant here, Garrett Dowell, who is doing a lot of great work on this area. I'm also just really excited to be part of this very cross-disciplinary panel discussion, because I think we're all coming at this from very different perspectives, and that's challenging, but I think it's also exciting. So I have been researching and writing in the past couple of years about the social media platforms' approaches to misinformation, and in particular, in the COVID context, I've been looking at the platform's responses to medical misinformation, and also in the context of the election of the past year, looking at their responses to political and election-related misinformation. But today I'm going to focus my discussion on the former, on the platform's approaches to regulating medical misinformation. So, it's no surprise that a large percentage of Americans get at least some of their news from social media today. And so that raises the issue of, what steps the social media platforms are taking to combat misinformation on their platforms, and in particular to combat medical misinformation on their platforms. Once we have an understanding of what these policies are, then we can consider whether those policies should be modified. So part of what I'm doing is taking a look at what those policies are, and also how they're being implemented, and what effect that has on our ability to access accurate information on social media. I'm a First Amendment professor, so I come at this from the perspective of First Amendment values, and not First Amendment law so much, because the platforms are private actors. They're not government actors, and so they are not regulated by the First Amendment. But our First Amendment, our free speech values in the United States influence their decision-making. So one of the key First Amendment values is that the preferred response to bad speech, the preferred response to harmful speech, is more speech, is counter speech, instead of censorship or removal. So that's the sort of default First Amendment response to bad speech, except in cases of emergency. If there's an emergency, then removal of bad speech or censorship of bad speech is warranted. So that, of course, raises the question of whether this context, the context of the pandemic, constitutes an emergency. So we can look at public opinion also on the issue of what do we think social media companies should restrict? What type of speech do we think social media companies should restrict? And this is a recent Knight Foundation Gallup poll from about 1.5 years ago. 85% of those surveyed said that platforms should prohibit and restrict intentionally misleading health or medical misinformation. So there's pretty broad support in this survey for the platforms taking measures to restrict intentionally misleading information about health or medical issues, what we might call disinformation, right? Medical disinformation. And indeed, all three of the major platforms, Facebook and Google, YouTube, and Twitter, have adopted pretty aggressive policies, increasingly more aggressive policies regarding the removal of COVID-related, pandemic-related misinformation, and in directing users to what we might call counter speech, authoritative, fact-checked, curated information about the pandemic. So we can ask, whether these policies are targeting the right type of speech for removal or labeling, whether they're doing enough, whether they can and should be doing more. Some might argue that they're doing too much, that they are too interventionist in their approach to medical misinformation. And we can also ask whether other strategies would be more effective, and of course, what impact this has on communities of color. Okay, so let's take a look at what each of the major platforms is doing, and I have links that are active here for us. So Facebook's response to medical misinformation and disinformation, with disinformation being intentionally misleading or inaccurate or false information. So Facebook indeed has a policy of removing certain types of content in this category, including content about how severe COVID is, about the prevention, transmission, cures, access to essential services related to the pandemic. So this whole category of content is subject to removal under Facebook's medical disinfo policies. And users themselves are empowered to flag content for removal. So if you see a post on Facebook, you can report the post and you can identify it as in violation of Facebook's medical mis or disinfo policies. So some content on the platform, on Facebook's platform, is subject to removal. Other less harmful posts are subject to labeling, or what we might say as a counter speech type approach. So Facebook has placed warning labels on a huge amount of content, approximately 190 million posts related to COVID-19. And according to Facebook, 95% of users do not proceed past these warning labels to the underlying content. So the labels, according to Facebook's data, they've placed a tremendous number of labels on content, and 95% of users actually do not proceed past those warning labels. Facebook's response also includes promoting and directing users to good content, to accurate information about the pandemic. So when someone searches for COVID-related information on Facebook, a pop-up surfaces with credible information, authoritative information from experts and governmental organizations like the WHO and the CDC. And 2 billion users on Facebook and Insta have been directed to these authoritative health sources, and 350 million have actually clicked through to the resources, according to the data. Facebook also sends corrective information to users who have interacted with COVID-related misinformation, and alerts users if they have engaged with or viewed harmful or misleading content. Okay, they're directed to, among other things, they're directed to the WHO's Mythbusters page. And here's an example of some of the corrective information, why this information has been removed, why we removed it, and authoritative information, what you can do, facts about COVID-19, coronavirus news, etc. Examples of labeling and links to authoritative information are here. This is false information, see why, help your friends and family avoid false information about COVID-19. So a lot of engagement as far as removing content, labeling content, directing users to authoritative content. Facebook, notwithstanding all this, Facebook was put on the defensive since a recent report on the disinformation dozen. Back just a month ago, a report from the Center for Countering Digital Hate identified that 65% of anti-vaccine disinformation online and 73% of Facebook's anti-vaccination content could be traced to just these 12 individuals or organizations. And in response, Facebook did deplatform the majority of these accounts that were linked to people who were involved in this. There is, of course, concern that these accounts will find a way to reemerge under different names. So we have something of a whack-a-mole type problem. And so one thing to study is how effective Facebook has been in keeping the disinformation dozens accounts from resurfacing, from reemerging. You wouldn't think that that would be that difficult for them to do. So that's Facebook. Twitter has a similar approach of removal of the most egregious medical information coupled with a counter speech or labeling approach to what they consider to be less egregious medical misinformation. So this, of course, has led to suspending Donald Trump Jr.'s account for claiming that hydroxychloroquine is effective and that wearing masks is not. Okay, so a whole large swath of medical misinformation that is misleading is subject to removal by Twitter's policies, including content that speaks to the nature of the virus, the safety or efficacy of preventive measures, etc., including claims that impersonate health authorities. So this type of information. And then Twitter also has this counter speech response, which, like Facebook, directing users to accurate information about the pandemic. Know the facts page, credible information is prioritized in searches. This is a partnership with 70 countries, including the United States, to take a number of different measures, including halting auto-suggest results that are likely to lead to non-credible content. Something that an approach that Twitter is taking that I think is quite interesting and novel is this pilot approach called the Birdwatch program. And this is something that GW is starting to get involved with, helping out with as well, which I'll explain in a moment. In this pilot program, users themselves are able to engage in and participate in fact-checking of content, and including medical misinformation in the COVID-19 disinformation area specifically. And GW University, with the Ethical Technology Initiative that I co-direct as part of, is working through the Health Communications Volunteer Corps to get involved in the Birdwatch pilot program to engage in responses to medical mis and disinformation on Twitter's platform. Twitter also has taken a number of similar steps to Facebook, but in the interest of time, I'll move on to Google and YouTube. Again, similar approaches, directing users to accurate information about the pandemic with an SOS alert page. Over 1 million videos removed by YouTube, information that speaks to COVID misinformation regarding treatment, prevention, diagnosis, transmission, subject to being removed. Notifications on Google tend to look like this. If you search for coronavirus, you'll get a message like this, right? And you'll get a link to the latest information from the CDC about COVID-19. So one of the areas of focus of our talk, of course, is looking at the effects of medical health and misinfo and disinfo on communities of color. And there are a whole host of issues under that category, but one that I would like to speak to is the issue of Spanish language content on the platforms. So the one particular issue that's received attention recently, that has been documented recently, is the lack of content moderation for Spanish language content. So Facebook, we saw earlier that Facebook places warnings on millions and millions of posts, but it does a lot more with respect to English language misinformation than it does with respect to Spanish language misinformation. So according to this recent study, Facebook placed warnings on only 30% of Spanish language misinformation, in contrast to Facebook placing warnings on 71% of English language misinformation. So quite a disparity there. And there's a number of activist groups, one recently called Ya Basta Facebook, that is pressing Facebook to be more proactive in properly labeling Spanish language misinformation as it does with English language misinformation. So in wrapping up, one of the initiatives that the GW Institute for Data, Democracy, and Politics is now undertaking is working with public health professor Lorraine Abrams on the Health Communications Volunteer Corps to help research and combat COVID mis and disinfo on social media. And the Corps has a Spanish language initiative called the Brigada Digital de Salud. And the Brigada is developing social media training for healthcare workers in communities that have lowest vaccination rates and higher COVID numbers, and is targeting outreach to Spanish language communities to research and combat COVID mis and disinfo. So hopefully efforts like these and focusing attention on Facebook's disparity in labeling misinformation in Spanish language content as compared to English language content, hopefully these efforts can make some progress as far as the effects of COVID mis and disinfo on some communities of color. So we've gotten a brief overview of what all of the three major platforms have been doing regarding, articulating aggressive policies for removing COVID-related misinformation, removal, and also counter speech, directing users to authoritative fact-checked COVID misinfo. And one issue that we can talk about in the Q&A is, not just the policies themselves, but the implementation, and maybe disparate implementation, issues of implementation at scale, right? Are there other strategies that the platforms can and should be taking to address this in a more equitable manner and in a more effective manner? So I look forward to your questions and your comments in Q&A. Thank you.
Okay, and I guess this is the green light for me to present. Okay, so I will share my screen now.
Yes, thank you, Dr. Punda.
Okay. Okay, it's a pleasure to be here with everyone today. I am Dr. Monica Ponder. I'm an epidemiologist and assistant professor of health communication and culture within the Department of Communication, Culture, and Media Studies at Howard University. Today's conversation, and I want to intentionally call it a conversation, so I'm looking forward to Q&A. It will add in health communication considerations to our larger conversation on misinformation and health disparities. I plan to share with you my positionality to this scholarship and encourage healthcare and public health practitioners to view interventions primarily through a cultural lens. I will end our conversation with a promising solution and opportunities for further engagement. And so I bring you greetings from the Good Life City, Albany, Georgia. Albany is one of the first COVID-19 hotspots in the nation. As you can see from the statistics provided here in the slide, Albany is a predominantly Black town with a long history of racialized terror. In addition, its public health system is centralized, meaning it is dependent on the state of Georgia's political and public health leadership for resources. A funeral held on February 29th, 2020, hit like a bomb, according to the New York Times. And the city has experienced many spikes since, and to date has been characterized as a site of the fourth highest community incidence of COVID-19 in the US by the CDC. But the tragedy does not stop there. And this is the trend even as of September 13th. I've taken personal and professional curiosity in how their health system handled COVID-19 crisis communications. I have a forthcoming publication that explores the use of Black trauma as COVID-19 crisis communication tactic. As you can see here, the hospital system, during the peak of the first outbreak, posted a 34-second video of a white healthcare worker dressed in full personal protective equipment that in the ICU room of a dying COVID-19 patient. The healthcare worker is then seen holding a tablet up for the patient so that they can say their final goodbyes to their family before passing away. The patient's face is slightly blurred out, but it is evident that the patient is a darker skinned Black man. The video ends with the hospital system's logo displayed. Playing in the background is a cheerful piano instrumental, Downloading Landscapes, by Andrew Michael Britton and David Goldsmith. The video is captioned to tout the hospital's world-class reputation. By centering itself as a recognized leader in healthcare provision, with no mention of outward sympathy for the patient or community residents or COVID-19 prevention messaging, the hospital system may have framed the video solely for its reputational benefit. As a result, some important questions arise. Whose emotion is centered in this post? The patient? His loved ones? The Black community witnessing this trauma? Or is it merely entertainment? While this goes beyond the scope of this presentation, there is historical context for promotion of the Black body in the structure of the white gaze, which works to humiliate the Black body via traumatic violating experience. Scholars have defined trauma as any experience that overwhelms your ability to cope and respond as your best self. Structural racism has created vast health and wealth inequities, along with creating vast differences of how Black people and other marginalized groups interact with and experience healthcare systems, healthcare providers, and health communication. According to the CDC, racial and ethnic minority groups are also unequally affected by unintended economic, social, and secondary health consequences of COVID-19 mitigation strategies, even social distancing. Health equity means that everyone has the opportunity to be as healthy as possible. Equitable opportunity includes equal access to and distribution of resources. When policies, programs, and systems that support health are equitable, poor health outcomes can be reduced. Health disparities can be prevented, and the whole society benefits. Unfortunately, some racial and ethnic minority groups continue to be disproportionately affected by COVID-19, and conditions in places where people live, learn, work, and play, and worship affect a wide range of health risks. And even this graph by Kaiser Family Foundation just even takes it a step further. The disparate impacts of COVID-19 pandemic, ongoing incidents of police brutality, and recent rise in Asian hate crimes have brought health and healthcare disparities into sharper focus among the media and public. However, health and healthcare disparities are not new. They have been documented for decades and reflect longstanding structural and systemic inequalities, inequities rooted in racism and discrimination. My scholarship underscores boldly that there are some cultural groups who are in a constant state of crisis. For health communicators in particular, this means developing crisis communication with even more considerations in mind. For example, how stigma, social stigma, contributes to harmful norms and continued racism, especially during a global pandemic. The crisis becomes layered and seemingly never ends. We have to consider the long-standing impacts of historical and real-time community level trauma and how it hardens distrust in public health leadership. In terms of vaccine equity, we have to go beyond reporting vaccination rates and uptake by race, ethnicity, and look at institutional context that keeps these communities oppressed despite willingness to respond to public health mitigation efforts. Essentially, framing matters. So what does this mean for health communication practitioners? And in this context, I'm meaning any communications professional that works in a healthcare, public health setting. First, we must listen to Black women. I saw this tweet, and it's one of my favorites. And it provides such a clear pathway of how longstanding individual and community harm, unfortunately, benefits many. We must understand the lived experiences people bring to their everyday health decisioning. Here's a great quote that I use often in my classes, and that really health is a social construct. The way people experience the world, their culture, their norms, even their everyday racism, the way they cope, is all a social experience. We cannot ignore that health is a social construct. To ignore this central premise affects our ability to truly impact health behavior, engender trust among historically unheard communities, and move towards health equity. And second, we must communicate with the understanding that many communities are navigating multiple crises every day, and they seemingly never end. As an example, we can just quickly look back to last week. And I can only imagine the impact on women and non-gender conforming people at the news of Texas's near total abortion ban. Not only is it dehumanizing, but it deputizes civilians to do what the state cannot, enforce the law, thereby contributing to just more trauma, fear, and harm. And so even if I want to take the women's health example, what does a practitioner do in health communication? To address these disparities and attacks and to keep people safe, does a public health practitioner pivot to shift policy and focus only on changing the environmental context in which people live? Does the practitioner need to build public support and action through public health education and social media intervention? Does the practitioner need to increase access to healthcare, remove system barriers, or even work with advocacy groups, like in this case, a Planned Parenthood or other groups that are coming to the forefront in response of the recent passage of that law? Or do we look at innovative ways to work with private corporations in finding solutions and thereby acknowledge the role that capitalism plays as a driver in so much of the US policies? So there are many routes a health communication practitioner can take. And I can understand how it can sometimes be very stressful. There is no one right answer because it depends on the case, but we do have a promising start. If I have not provided enough examples today, let me make my premise very clear. The way public health pursues crisis communication is insufficient, but there are best practices for crisis communication across leading disciplines like sociology and public relations that can teach us what a more ethical and culturally responsive response should be. This is the Henrietta hypothesis in honor of Mrs. Henrietta Lacks. There is so much more to her story than her harm and trauma. I would love to share my research with you in another context in future conversations, but let me just give you a highlight of some of the background. The Henrietta hypothesis is a new conceptual framework for how public health practitioners can pursue crisis communication. And it's also something that is intended to be evergreen and applicable in the digital environment. And it includes an interdisciplinary perspective that has not yet been seen in public health practice. And so here's a very quick snapshot of just some of the pros and cons of health communication, public relations, and sociology, of best practices in crisis communication, strengths and limitations. This is published elsewhere, and I'm happy to share that. But in order to do this, particularly when crises are sometimes unpredictable, sometimes constant, sometimes layered, sometimes as a result of longstanding historical harm, a model must be parsimonious. It must be able to be nimble and to respond not just to a new event, but also longstanding positions that keep the public protected. And in the model, the process that was gone through to create the model, we were very intentional to remove redundancies and use tactics like social listening and pre and post-crisis follow-up as routine practices in crisis communication. So there are 4 major synergies in this crisis communication model that have been grouped and categorized. But also there's a 5th category that is about collective movement. Many times health equity encompasses so many different fights and players and individual actors as well as collective actors. Even within the women's health example that I gave, something known as the model women's health movement, which has lasted a century, which includes so many noble, brave actions by many who have gotten women's health rights and freedoms to where they are today. But really, at the end of the day, crisis communication and public health, when you're dealing with the dynamic nature of people, it should be intuitive in terms of how you practice it. And so here's a very brief overview of the model itself. The 5 different categories of just really tactics that should be used if you are a practitioner for healthcare or public health. You should definitely hear people and document their experiences. And this can be used through storytelling and social listening and making sure you're responding to people. Secondly, clarify what exactly are the opportunities for issue alignment. Sometimes our biggest allies aren't in public health, they're in spaces like education and transportation, and solutions can sometimes look non-traditional. Third, and this is just coming mostly from the public relations literature, we have to also think of the reputation of the public health and healthcare organizations because we need continued trust. We can't harm and then go back in the next crisis and ask for an action or trust. This is a continual relationship. And then number 4 is just what public health does best. We must protect people. We must help people make the best decisions, health decisions for their lives, offering them reassurance and safety to do so. And also make sure that we are using the latest epidemiology and data and tools to make sure that we are able to make recommendations that protect even those at highest risk at all times. And then always, we should have a model advocacy approach. Our goal is the pursuit of health equity and responsive action. And so here is the model itself, and I'm happy to share again if anyone wants to reach out to me. My email is at the end of this presentation. But I do want to end the presentation and talk about just future directions for practice. Number 1, we want to build on existing research. Crisis communication is not a new field. I do believe the way public health pursues crisis communication could be tweaked and improved. And we should demonstrate not just this model's utility, but just different ways to support communities, one that is culturally centered, culturally sound, and always evaluate what has worked and what may have unfortunately harmed. And then plus we need to assess which strategies may be used most in some contexts and less in others. And this is really responding to the dynamic nature of crises. And definitely necessary practice guidance. Does a health department in Albany, Georgia practice crisis communication as the same as a health department in Los Angeles, California? What are the synergies and where do they diverge? And then there are also just broader gaps in health and crisis communication that particularly my other co-panelists have mentioned, so I won't elaborate here. The second opportunity before I end is a project that I co-lead. It's called Project Refocus. And public health practitioners also need the tools to monitor stress, community distress, and signals of that in real time. That means we must look at surveillance systems differently. And Project Refocus was purposed to really reframe how we view surveillance, actually centering the community, empowering them to use their data for their own advocacy. And so these are just some of the campaign graphics from our first phase of work. This work is funded by the CDC Foundation, and our partner in this work, so it's Howard University and UCLA's Center for the Study of Racism, Social Justice, and Health. And I do want to make sure that I give credit to all the students and co-faculty members who are collaborators in this project, including SRB Communications, who was our lead communications firm for this work at Howard. And the last is we must train future public health leaders. And I'm going to give a plug for my department. CCMS is Ph.D. only, and we are here to make sure students are trained to focus on the communication problems that are most complex and are most important in our world. And particularly in the health communication track, we focus on critical health communication. Critical health communication interrogates the structures within which meanings of health are constituted, raising questions such as, how are the agendas of the status quo played out through the framing of specific problems in health communication research? What are the dominant ideologies that circulate in the privilege of certain sets of scientific claims in health communication? What are the values embedded in the claims to scientific legitimacy made by health communication research? And how are these values situated amid the political and economic agendas of dominant power structures? So it's beyond individual context and blame. I'm making this plug because we welcome applicants this year for entrance into our next cohort. And with that, I want to thank you for your time. You may follow me on Twitter at Monica L. Ponder, and here's my email address if you'd like to remain in contact. Thank you.
Thank you so much, Dr. Ponder. Thank you to all of our panelists, Ms. Chen, Professor Nunziato, and Dr. Ponder. We appreciate you volunteering your time and expertise and participating in this event. So I know we have a few questions. If you could stand by, we want to ask those couple of questions to you. We do have a question from Monica Hodge, and her question, she did not direct it to anyone in particular, so anyone can speak up. How do we continue to address disinformation and fears among minorities regarding getting vaccinated for COVID? So she knows a few people personally who just refuse to take the vaccine. I know that all of us know people who refuse to take the vaccine, not because of current health conditions, but due to the fears, despite the growing number of cases. How do we address that?
I'll start from a health communication standpoint. Going back to what I mentioned in my presentation, there are just some cultural groups that are in constant state of crisis. And I'm of the belief that many people can't take the best actions if they don't feel safe. So the first is restorative care. It is helping people cope and heal with their everyday reality. And there's been a lot of harm done in the pandemic. So we're not starting from zero. We have to go back to the start of the pandemic. And even before, for some groups, the historical harm. We must meet people where they are and hear them and take serious their concerns. From there, we need a multi-layered solution in terms of what it will take to understand their barriers to health behavior. And sometimes that means new investments or non-traditional investments in how we traditionally do public health. So I don't want to say that it's just talking points, or we should just, ram a message down people's heads. We have to take care with people's lived experiences.
Anyone else? If there are no more responses.
I just wanted to
then-
say, I agree with
Okay,
everything.
Go ahead,
that-
Professor.
I agree with everything that Dr. Ponder said, and I think especially, to underscore meeting people where they are, right, and not having a sort of one size fits all approach to this. I do think that, to some degree, having subgroups and specialty groups online on the online platforms is something that can be helpful in that regard. And I think that it continues to be important for the platforms to respect a diversity of experiences while removing and responding to the most harmful types of disinformation in the COVID space.
And you're absolutely right, Professor, and meeting people where they are. We talked a little bit earlier with Dr. Pearl, and we brought that up. You have to go to those communities. You have to go to their churches, civic organizations, and get them involved and be able to educate and inform them. I know that Project Refocus, Dr. Ponder, you mentioned that earlier. That's the next step over the next couple of years for Project Refocus. You want to talk a little bit about that?
Yeah, so particularly from, I smiled when I saw Irene's presentation, because our data science portion of the project is led by UCLA's team. But people talk to us all the time. And I think even all the presenters here have said the same thing in terms of the data are there. How do we listen better in public health? And how do we make sure communities have ownership of that data? Right. And so that we even remove the stigma from quote unquote surveillance from the state, but really it's people are talking to us all the time. So how do we hear them? And so what does that look like from a surveillance infrastructure standpoint? This is what Project Refocus is intended to figure out, and then work with select communities to pilot our dashboard to actually see what signals can be cultivated, and how we can make sure that this baton is a smooth process within a community when a community shows that it is in distress.
Thank you so much, panelists, again for joining us. For more resources and references for today's symposium, there are links to each of our presenters' articles. That's right there in the chat. You can go to the chat and you can get that. Thank you all for joining us today. I also want to take this time to thank all of the participants today, panelists. The provost from Howard University joined us earlier, Dr. Pearl, a medical doctor, and so many others. But most importantly, we sometimes don't get to thank those people behind the scenes that are so important for pulling this type of symposium together. So I want to take that time now to thank the coordinator of this program, Health Sciences Library representatives, Dr. Fatima Barnes and Jeremy Gunno, and Law Library representatives, Eileen Santos and Quintarian Waits. Thank you all so much. I want to remind all of the participants today to register for tomorrow's event. We'd like to see you back here. There's so much insightful information and wisdom that you can get from our panelists, our scholars, that you can share with others in your communities, in your schools, in your programs and initiatives. Tomorrow, we will focus on legal policies and disinformation. So join us tomorrow. We look forward to seeing you. It's been a pleasure to be your moderator for today's session. There will be another moderator tomorrow. Thank you for joining us and have a fantastic day.
Yeah.
Thank you so much. Thanks,
Thank you,
everyone.
Dr. Brooks. Thank you.
Thank you.
Thank you, everyone.